So I always try to tell the physicians and the nurse practitioners and the physician's assistants and other, providers that, you don't really need, as a non-gastropsychologist or as a non-mental health professional providing brain gut behavior therapy, you don't really need to decide between which type of behavioral therapy you're going to recommend to your patient. It's always better to send your patient to a professional to assess and find out what might work for them. And we're going to hear a great talk from Dr. Reel around what that means. But what I really wanted to point out in this slide is that, we have several classes, but the three main classes of brain gut behavior therapy, and maybe even the main two therapies, are cognitive behavior therapy and gut-directed hypnotherapy. And it's important to recognize that these, as a class, brain gut behavior therapies are clinician administered therapies, right? To be called a brain gut behavior therapy, it would be a clinician administered, meaning there is a theoretical framework that is driving the decision to choose between cognitive behavior therapy, gut-directed hypnotherapy, mindfulness-based stress reduction. We have psychodynamic interpersonal therapy. We have self-management therapy. But there's a theoretical framework as to what the problem underlying the patient's particular symptoms is and how that might be remediated over time. And that drives the choice of therapy. And the other nice thing about that theoretical framework is that once you understand what the patient's symptoms are, you can combine interventions. You could do cognitive behavior therapy with a patient, but add hypnosis. You could prioritize hypnosis, but also do some cognitive things. And we'll hear a little bit more about that later. But I mentioned my targets, the 5 targets that have come out of the Rome working team, and which ones might be addressed by each of the classes of therapy, and then also the type of provider. So one nice thing about gut-directed hypnotherapy and mindfulness, for example, is that they can be provided by non-mental health professionals. They can be provided by, we have some doctors that have been trained in hypnotherapy. We have nurse practitioners that have been trained in hypnotherapy. The evidence base is obviously the strongest for both CBT and hypnosis in IBS, as well with cognitive behavior therapy also demonstrating some improvements in dyspepsia, non-cardiac chest pain, and cost effectiveness in IBS. Hypnosis can often be adapted based on symptoms as well as other conditions such as, functional dyspepsia, non-cardiac chest pain, duodenal ulcers, that type of thing. And there are also several delivery methods that can be offered to patients. And we're going to hear some talks about how you might be able to improve access through different delivery. And Dr. Reel is going to talk a little bit about both psychoeducation and groups, as well as digital and online delivery in a little while.